Dr. Marin for that introduction. And today I'm going to try to give you some idea of the contributions at Mount Sinai Hospital, particularly with regard to Crohn's disease. As Dr. Marin mentioned, a lot of people have worked with me over the years, and this is a summary of some of them, and there are many others. Students, fellows, and fellows from Japan, Brazil, Israel, and Holland who've worked with me, in addition to the students at Sinai and the residents at this hospital. This work couldn't have been done without their assistance, and we'll start off with the early descriptions of this disease: ileal masses by Morgagni in '69, obstruction with colonic skipped areas by Komen-Saunders in 1813, and stenosis of the terminal ileum with fistulas in 1889. In 1901, Lartigot described non-caseating granulomas, which distinguished this disease from tuberculosis. And in 1902, Mayer-Robson described 3 of 7 TB cases, which actually proved to be Crohn's disease. Moynihan did a proctectomy for Crohn's disease mimic cancer. The first person to actually give a definitive description of this disease was Deal. Deal in England in 1913 wrote a paper which was elaborated and made more concise by the subsequent paper from Mount Sinai Hospital. And he described the bowel as being the consistency and smoothness of an eel in rigor mortis, and the glands, although enlarged and evidently non-caseous. And this shows a little bit of what he saw when he looked at the first cases of this disease. Dr. Crohn wrote the classic paper in which he actually described the disease in detail, which we know today. We propose to describe in its pathological and clinical details the disease of the terminal ileum, affecting mainly young adults, characterized by subacute or chronic necrotizing and cicatrizing inflammation. Our average age is our mean age about 25 years of age. The ulceration of the mucosa accompanied by a disproportionate connective tissue reaction of the remaining walls of the involved intestine, a process which frequently leads to stenosis of the lumen associated with the formation of multiple fistulas. Dr. Ginsberg was the person who really recognized the disease. He was in our department of surgery before most of you people were in the department or came to these lectures, and he described it in detail in the pathology. I actually have an original paper by him where he showed me which parts he had written and which parts Dr. Crohn had written. Dr. Crohn wrote up this clinical, and he wrote up just about all the details of the actual disease. He described this disease in 1933 in the colon, before Crohn actually accepted this, because he didn't accept Crohn's colitis until 1966. The characterization, incidence, and distribution in epidemiology will be now looked at. Ulcerative colitis, as you know, is a disease of the colon. It involves the mucosa only, unless the disease is extremely severe. It does not recur, although we do get pouchitis in some of the pouches we create, and it can be cured, whereas Crohn's disease is panenteric, transmural, and we palliate the disease because it can always come back. If we look at the incidence and prevalence of this disease, 2 to 7 and 1 to 7 for Crohn's disease, 4 to 100 and 10 to 100 for Crohn's disease. The probability of the disease in 2 siblings is 0.00001, and observed frequently in our patients, 5 to 10% and 10 to 35% respectively for ulcerative colitis and Crohn's disease. And the disease frequency, 7% and 24% in our patients. This shows the worldwide distribution of Crohn's disease, which is most common in Europe and in America, and this is the incidence in our patients. As you see, 43% of our patients were ulcerative colitis in a large collected series of 2682 patients, which I collected over the years, and 24% were ileocolitis, 10% Crohn's colitis without any small bowel disease, and 22%. If you look at the actual incidence in granulomatous colitis, these are the incidence, and there's actually a 16% incidence of pure Crohn's colitis. The evidence for a panenteric disease is quite significant. The anatomical evidence is disease. I've had a patient who has disease in the esophagus, the stomach, the duodenum, 30 fistulas of the small bowel, and I did 13 strictureplasties, a gastroenterostomy on this particular patient, and then she lived for 5 years until she got a very long stricture of her esophagus. There are also biochemical, immunologic, and physiological evidence for this being panenteric. Sodium flux occurs in normal bowel, and there are multiple cancers, particularly in normal bowel as well. The anatomic disease of the esophagus, biochemical, immunological, and, as mentioned above, three types of disease may be described. Non-perforating with fibrosis and obstruction, perforating, acute, subacute, and chronic, free perforation being acute, abscess formation being subacute, and fistulization being chronic. This is an example of Crohn's disease, and you can see over here, if you look at there are geographic ulcers here which bled. There's cobblestoning over here, and here's cobblestoning and longitudinal ulcers. That's a typical case of Crohn's disease of the colon, and this is the longitudinal ulcers that you see in some of the patients. This is a case of disease localized to the rectum in which a cancer developed. That's very unusual to be localized to the rectum. Most of the Crohn's disease, as you know, occurs on the right side. Now, the first thing that I looked at one of the first things was the extraintestinal manifestations of this disease. And I was able to define colon-related, small bowel-related, and non-specific forms of extraintestinal manifestations. Now, group A, the colitis-related, were the joint, skin, mouth, and eye manifestations. The small bowel-related, which occurred with malabsorption, gallstones, renal stones, and non-calculous hydronephrosis, and finally, osteoporosis, liver, peptic ulcer, and amyloid disease being non-specific. And as you can see here, there's significantly more of the skin, eye, joint, and mouth manifestations in the colon, and this has been established by other papers that have been written on the subject. This is a case of gallstones in a patient with small bowel obstruction and fluid levels. And the small bowel GIC and regional enteritis, ileocolitis and regional enteritis, much more common, only really occur in the small bowel, and obviously that's where the problem would be. The next slide is based on Dr. Pertzum-Leedy's work that he did in the lab, but actually, if more than 100 centimeters are resected, we get a choleritic diarrhea, and if more than 200 centimeters is resected, one gets steatorrhea, fatty acid steatorrhea. Here the problem is the bile acids getting into the colon, which cause decreased absorption of sodium, chloride, carbon dioxide, and water, whereas with the steatorrhea patients, you get fatty acids going into the stool. And so we have the choleratic diarrhea, bile salts in the colon, hydroxy fatty acids and micelle formation with steatorrhea, and gallstones due to bile salt pool abnormalities, and urinary stones. We now think differently from the original glyoxylate theory, but these are the complications that we looked at. Osteoporosis and osteomalacia might occur in any of the bones, and this is a case where the bones just collapsed from this particular manifestation of the disease. Now, looking at the etiology of Crohn's disease, I'm sure you'll all be very surprised to note that Dr. Marin was one of the first contributors to work on the etiology of the disease. I'm not going to go into that. This really wasn't my field, but he wrote a paper with me on alterations in the tight junctions, barrier function, and freeze fracture electron technique was used. There were 5 consecutive papers after this, or during this period of time, which I wrote in the American Journal of Gastroenterology. They were on fistulas. 23% of all fistulas and 37.5% of external fistulas originated in the colon. 82% of patients with fistula and 49% without fistula required surgery. Hemorrhage was then looked at, of which there was overt hemorrhage in our patients, 32%, guaiac-positive stools in 11%, massive hemorrhage in 2%, and anemia in 40% of the large bowel cases and 75% of the other cases. Toxic megacolon was the next paper, and at this stage there was considerable debate at Sinai whether toxic megacolon could occur with Crohn's disease, and in fact one of the senior radiologists said it could not occur, and then when I wrote this paper, he wrote a letter to the journal saying that this disease did not in fact occur. There was no such a thing as Crohn's disease with toxic megacolon. And then looking back at his own papers, there were 2 patients of clearly defined Crohn's disease with toxic megacolon. I then looked at the clinical features and retroperitoneal abscesses. The surgery of Crohn's disease is now what I'm going to examine. There have been several types of surgery during the course of the last 50 years. Open surgery, radical surgery in 1950s to 80s, bypass surgery, minimal excision, and strictureplasty in 1977, and laparoscopic surgery in the 80s. The first 14 of 18 cases are seen here, which were all done open by Dr. A.A. Berg, and they were only 14 of the 18 cases had specimens, and they were described in the original article. The first actuarial study of disease was done at this hospital, and this was published in the New England Journal of Medicine, which shows the inexorable tendency of Crohn's ileocolitis to require repeated reoperations, and this was demonstrated by actuarial methods for the first time. The era of radical resection was next, and or had occurred before that time. And in 1952, Drs. Culp and Dreiling wrote a paper suggesting that 2 feet of bowel should be resected on either side in order to cure the disease. Subsequently, in Sweden, Wallenstein, Krauss, and Karlsson wrote similar papers suggesting we should do a radical resection to cure the disease. When it was realized that Crohn's disease could not actually be cured, the amount of bowel resected got less and less, went from 10 centimeters, and it was about 2 centimeters when I arrived at this hospital. Subsequently, Lee, in 1978, who visited India and saw Kataraya doing strictureplasties for tuberculosis came back to England and did the first strictureplasties there. Alexander Williams followed a few years later in England, and we started doing these procedures in America. Bypass surgery was an era which was done, and as was suggested today with this case, might even be useful in this day and age. The Eisenhower operation was essentially a side-to-side iliotransverse colostomy. And most people then started doing an exclusion procedure where they transected the distal ileum and reanastomosed the proximal loop of small bowel to the transverse colon. However, there were many complications with these, some of which were cancers. And I was able to collect a series of 7 cancers in bypass segments of this disease. And this was at Mount Sinai Hospital between 1960 and 1980. 3 were in the small bowel, 4 in the large bowel. And 3 of these patients, interestingly enough, had enterovesical fistulae. When we looked at the survival of patients with colorectal adenocarcinoma and Crohn's disease, patients with incontinuity carcinoma did much better than those with diversionary cancers. And this applied both to the small bowel and to the large bowel. All these patients with diverted cancers being dead by about 20 months. The ultimate bowel-saving surgery at the expense of leaving disease was strictureplasty, and this was the next phase. And now we use strictureplasty for certain patients where we have multiple surgery. The more experienced a surgeon, the less the adhesions, the fewer the previous operations, the greater the proportion of cases that can be done laparoscopically. The first randomized controlled trial of laparoscopic surgery was done by Milsom, and Salke has written many papers indicating the advantage of laparoscopic surgery for complicated Crohn's disease. 3 types of disease: non-perforating, perforating, and inflammatory. We look particularly at the former 2. Indications for surgery are failure of medical management, intractable inflammatory disease, pain, weight loss, and there were complications. The complications were perforating and non-perforating. Now, we looked at the perforating and non-perforating disease and showed a highly significant concordance to the 3rd operation of perforating versus non-perforating disease with a high degree of significance. And this is the findings of the first resection, 375 patients. 49% were perforating, 51% were non-perforating. But of the perforating, 73% were perforating the next time, and 71% of the non-perforating the following time. We found the same thing from the 2nd to the 3rd operation. Once you have a form of disease, either perforating or non-perforating, the probability is very high that it will do the same thing the next time. And if you look at non-perforating, first operation, 8.8 years before a recurrence. First operation for perforating, 4.7 years, and even shorter time for the second operation. The complications requiring surgical intervention are acute free perforation, where we drain the abdomen, wash it out, do a resection, and sometimes do an ileostomy, most times if there's extensive peritonitis. Subacute, we drain the abscess, usually percutaneously these days, and we use antibiotics for drainage and resection. And then chronic fistula, we do a resection, usually en bloc. The fistulae in Crohn's disease, incidence of fistulae internal 22%, external 6%, and both 4%. These are external fistulae: iliocutaneous, colocutaneous, Jejunocutaneous and gastrocutaneous are pretty rare. And this shows some external fistulae where you have to do debridement and resection of the underlying bowel disease. This shows periileostomy fistulae, which we see quite a number of here, where we resect the ileostomy, transpose it to the other side, and do a debridement of the skin. Fistulae in Crohn's disease, looking at the internal ones, you can see an internal fistula in the next one. This is an internal fistula here, and there we see the thickened bowel wall of the Crohn's disease, and here's the terminal ileum. Now, the enteric fistulae in Crohn's disease in 480 patients with this disease, most common ileosigmoid, ileocolic, enterocavitary, jejunocolic, colocolic, and duodenocolic were the next most frequent from our database. And this shows over here a dilated segment of small bowel, a very diseased segment of colon, 2 fistulae, one here and one here. We had to do an ileocolic resection, an anterior section, and 2 reanastomoses to treat this patient. Here we see a patient with cologastric fistulae. Look how bad a disease the colon is. And then from the left transverse colon is a fistula to the stomach. And this is a very interesting patient of mine, 20 years old when I first saw her. She had severe disease of the colon. She had a normal jejunum at that site, actually, to the diseased colon. I had to do a colonic resection, ileostomy, and then subsequently, 12 years later, she came back with multiple small bowel strictures. She married one of our physicians. She's still alive, and she's had 2 more operations since that time. And this is her specimen, and there's the fistula. There's the diseased terminal ileum, which had to be resected with the initial specimen. Now, genitourinary fistulas are quite common in this disease, and the types of genitourinary fistulas are rectovaginal, ileovaginal, colovaginal, a few, but most of them rectovaginal and ileovesical. And this shows a fistula from the bladder, which is here, going up to the small bowel, which is over here. Ileovesical fistula, which is not uncommon. And we saw ileovesical fistula here's another one, in 38 patients, which were studied with Dr. Tsakis, who now runs a transplant service down in Florida. This is a patient who has a duodenal fistula in Crohn's disease, an enteroduodenocolonic fistula. We'll talk about that in a minute. So strictures of the small bowel are the next issue I'm going to quickly discuss. Most strictures are single strictures. They show thickened bowel wall. They show a single stricture. And they do an ileocolic resection with reanastomosis for those patients. However, multiple small bowel strictures are a much more challenging problem. The decision to use strictureplasty is dependent on clinical judgment. The ideal patient is one with multiple small bowel strictures and a normal bowel in between with a short bowel. The sites of the multiple small bowel strictures are shown here. We had 41 were in the jejunal-ileum, 62%, 15, 22% in the jejunal-ileocolon, ileocolitis 7, duodenojejunocolitis 2, and ileitis in 1. Notice that 86.5% of multiple strictures involve the jejunum, whereas most of the single strictures are in the small bowel. Now, the basic types of strictureplasty which we do we do for these multiple strictures are Heinecke-Michelix, Finney, and Michelossi. Looking at the Heinecke-Michelix fistulas, the Indian ones done in India for tuberculosis in 77 by Kataria. In 77, Lee did the first ones in England, and then Moskell described one with a double Y at the dilated segment of bowel. Fazio described as a double stricture, strictureplasty, and Judd described one with fistulas. You can actually do this with fistulas provided that you resect the fistula. This is how the Heinecke-Michelix is done: longitudinal incision and a transverse closure. And Judd is the same thing, where you resect the fistula and then you take the normal bowel on either side and do a transverse closure. And this just shows how strictureplasty is done in our patients. Secondly, we did the Finney strictureplasty, where you may do a side-to-side, which is called a jaboulet, and you may do a selvaggi, where you connect the bowel to the end of the Finney strictureplasty. This is a typical Finney strictureplasty, where you do you have actually a long side area which is out of the circuit, really, although the stool goes in and then gets emptied out through there. This should be done in patients who have more than 10 centimeter stricture. All the ones 10 centimeter or less can be done by a typical Heinecke-Michelix. And then finally, there's a Michelossi strictureplasty, where there are a number of varieties. The interesting thing about this is that you do a longitudinal incision. You then transect the bowel right across. You then turn the bowel over side to side, and you suture this side to the side and the lateral sides to the lateral sides. And this type of strictureplasty is not done very often, and it's quite difficult to do. And you can do this with double Heinecke-Michelix at either end. You could do this procedure with resection, and you can do this procedure with disease to normal bowel as opposed to disease. This shows disease to disease bowel, but you can actually do it to normal bowel. So there are a number of varieties of strictureplasty, and you have to decide which is the most appropriate in each case. So this shows the rates of recurrence that we looked at in a paper where we examined patients with more or less than 8 strictures and more or less than 4 strictureplasties. And you can see that patients with more than 8 strictures have a more rapid recurrence of the disease, and patients with more than 4 strictureplasties have a more rapid recurrence of disease. This is a case that shows a stricture here, over here, and over here. And here we see a lot of very dark fecaliths. Patient developed a 10 centimeter cancer, was married to an oncologist. I resected this, and actually he was still alive at 4 or 5 years, which surprised me because this was a 10 centimeter size lesion, but he, interestingly enough, had no lymph nodes. So in conclusion, Crohn's disease, first described by Deal in 1913, Crohn, Ginsberg, and Oppenheimer brought it to international attention. It is a panenteric disease with extraintestinal manifestations, which are small bowel and colon related. Treatment is medical and surgical. Surgical is by resection, strictureplasty, or rarely bypass. And the surgical indications are inflammatory, perforating, and non-perforating. Recurrence is common and not prevented by radical resection. Although chronic and sometimes debilitating disease, symptoms can be controlled by medical and surgical treatment. And we can give the patients a reasonable quality of life with these operations if they are done appropriately at the right time and without complication.